The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're very fortunate this month to be talking to Pat Cartwright, a great urologist in Salt Lake who has really just done a lot of great things and is a great teacher. So welcome back, Pat.
Hey, Paul. Thanks for having me again.
It's interesting to me that we sort of treat uncircumcised males as being an anomaly in some ways. Before I go further, have you developed any conflicts?
No conflicts.
Okay. So I did some looking because people do ask sometimes how prevalent circumcision is. And the best numbers I could find from the NIH study from 2016 is that between 61 and 63% of men in the world are not circumcised. Somewhere around the flip of that, so about 70% of males in the United States are circumcised. But I think that because of that, people end up being flummoxed as how to give appropriate guidance to families. So I was hoping you could help us sort that out a little bit.
Happy to do my best.
And I think as a result, sometimes I think people do get flummoxed about notions of when to refer phimosis and that sort of thing. So first of all, does an uncircumcised penis have any very difficult hygiene requirements?
So the answer is no for the majority of patients, and certainly for infants and young kids. The best thing is leave the penis alone unless it's causing a problem. So cleaning the outside of the penis like it's another finger is kind of what I recommend. So the same soaps, everything is fine to do. No attempt at retraction is needed. The newborn penis almost always cannot have the foreskin retracted. Two issues. One is small preputial aperture at birth, and the other is just interpreputial adhesions, which attach probably 70 to 90% of the glands has interpreputial adhesion. So even if the aperture is big enough to pull back and see the meatus, you'll often quickly see interpreputial skin still attached to the glands. That detaches, and just what we're going to talk about, over time with high variability in terms of timing and things that happen along the way. But in virtually all will detach over time. Forcing it too early is definitely a source of trouble. So if you can force it back in a number of kids, you'll often tear the foreskin slightly, which then predisposes to scarring and later true phimosis, as opposed to what we just talked about, which I would call physiologic or normal phimosis or inability to retract the foreskin. The other thing that will happen if you force it back early is you tear apart the interpreputial adhesions. Now that's normally done with circumcision. Those are teased apart. It's a light adherence of inner foreskin to glands. But when you circumcise, you then have no foreskin to come back over the irritated glands. If you push those down forcibly, the inner foreskin then rolls back in position and loves to form more permanent bonding, skin bridges and other things, which won't release over time. So you kind of cause trouble in at least a couple different ways if you retract early.
So someone will ask, by what age should I worry about this not retracting?
I think there's been, and you and I were talking about this previously, there's been sort of handed down expectations or norms, like it should happen by age 3 or it should happen by age 5. And I think it's probably training program specific. And there's data that would suggest, some of it suggests by age 5, 85 to 90% retract. I don't think I believe it. I've looked at that data in the past, and it's hard to know exactly how they got that. But I would say a higher percentage take longer than that. And in reality, I think almost any pediatrician you talk to will say, I don't have an age by which I think it should be retractile, other than at puberty. And once they're in early to mid puberty, they need to be able to retract and clean beneath, or they will have problematic hygiene issues over time. So puberty is probably the real answer when anybody asks me, and when families ask me, I tell them that as well. I think it's distressing to families because they'll have high variability in their kids. One kid at age 2 has a huge open foreskin that pushes back and forth easily, easy to do, no problem. And then another kid in the family will be 8 and can't do it. And well, that's just the range of what normal foreskins do.
Let me ask you to go out on a limb as a pediatric urologist here. Can an uncircumcised boy toilet train before his foreskin will retract?
Definitely can.
Okay.
And they do commonly. People ask about care, and my basic recommendations are leave it alone, clean the outside like another finger until they get to be the age at which you think you can coach them into managing their toilet training in some fashion. When they first toilet train, they're just good to roughly get to the toilet and hit the water 50% of the time, that kind of thing. When they're older and you think they're coachable, teaching them to retract foreskin to the extent possible, and that usually can be, part of the glands exposed, but getting the foreskin out of the way of the meatus is an advantage. 2 things: you shoot straighter. Second thing is you pool less urine under the foreskin, which I'm very convinced is the cause of recurrent inflammation of the foreskin in lots of uncircumcised boys. Not the ballooning thing, which I think we'll talk about, but just the kid who freehand, hands in the air, roller coaster style, peeing in the toilet, doesn't pull his foreskin back at all, in a hurry like most little boys, a few dribbles at the end that he then runs off and leaves the urine sitting under the foreskin, causes a little bit of smell, causes a little bit of irritation and burning. People sometimes think it's, quote, balanitis, where it's probably just chemical irritation from retained urine. So when they're coachable, pull the foreskin back as much as you can. You'll hit the toilet more often. You'll have less irritation. Dab the penis with toilet tissue at the end to get those last couple drops off to avoid the same thing.
Let's talk about ballooning. What happens with ballooning and when should parents worry about ballooning?
So ballooning's an interesting one, and it is a bit of a problem, right? 2 things. One is they dribble often after they're through voiding, and if they're not careful and express it, they'll dribble in their underwear. They tend to have an odor because bacteria get under there, and they're more prone to inflammation and pain. So kids who have true ballooning, I worry about. There's kind of an interesting thing, Paul, and I don't think anybody's ever reported it, but you'll notice it. If you look at a foreskin, so I'll see a kid who's uncircumcised, and parents will say, he's had some pain, and I'll examine him before I ask him all the history. And if I see, instead of preputial opening that's like right at the end of the foreskin, instead if it's dorsally located, sort of on top of the foreskin, I'll always ask him, was this ballooning? And usually the answer will be yes. So that abnormally placed preputial opening is, I don't know exactly if it's secondary or primary, but sort of like the urine pools under the foreskin, it ends up dilating the ventral or under foreskin and then rolling the preputial aperture to a higher location. If kids have ballooning and have had more than one episode of balanitis, that probably is going to require an intervention, or they're going to have more of that. Whether it's topical steroids, which we can talk about a little more, or circumcision or dorsal slit or something to relieve the ballooning, because that portends more trouble.
What can you tell me about preputial cysts?
So you can have different sorts of cysts. There's a parameatal cyst. There's a midline raphe cyst, which, obviously is ventrally, just where the raphe and the frenulum come to tip of penis. With preputial cyst, that's extremely rare to have a true epithelial cyst of the prepuce. Really common, though, is smegma trapped under foreskin. And people will come in telling you it's a cyst, seeing whitish, thick discharge from it, that kind of thing. And I mean, that's just interpreputial layer separating from glands as smegma built up underneath it. So should be emphasized to them. That's a normal and helpful thing for the separation. Rarely do they get infected. You'll see a kid occasionally where I think the adhesions have persisted on one side and they almost have a pocket where smegma developed and separated preputial adhesions on the other. And something about their anatomy makes them really prone to recurrent colonization. So there are those rare kids that may need circumcision or something based on getting recurrently infected where a smegma pocket was before.
What should we be telling parents and boys about the care of smegma?
Leave it. If you notice it, it's not infection generally. It's going to be whitish, thicker than you would expect pus to be. Clean it off when you see it. When they retract the foreskin, usually the best thing is kids usually discover sort of pulling the foreskin back, I would say, in the bathtub or the shower, since it's sort of like a favorite bath time toy sort of thing. And when they do pull it back, usually something like baby soap, not non-irritating soap is the best thing to clean under the area. Don't force the adhesions like we were talking about. Slowly retracting each time they void is a thing to teach them, like we were sort of going over. If they do that and clean underneath, I think their adhesions are highly likely to release over time and not be an issue.
Okay. All right. So let's move on to phimosis for a minute. How is phimosis defined? Because we've talked about the fact that we don't expect it to retract until it's ready to retract. So what's phimosis?
Yeah. So phimosis, by definition, is just a non-retractile foreskin. So it's normal and physiologic early on. Pathologic phimosis is, where at puberty, they can't retract their foreskin. And at that point, that's an issue. In between, if they can't retract, we don't, like we sort of talked about, we're not very worried about it unless they have issues associated with it: ballooning, recurrent infection, pain. The other thing that makes us suspect pathologic phimosis is on exam, when you push the foreskin back, usually it's fairly thin and essentially will efface, right? Or get thinner as you push it back. You almost get the idea if you push hard enough, you could just release the interpreputial adhesions, which is correct. If it's thickened when you push the preputial aperture back, thickened skin, whitish, doesn't efface, stays thicker than you would expect, they may have formed scar tissue within the foreskin that's going to portend poor potential resolution over time. When you see that thickening and inability to retract, even a 7 or 8-year-old, especially if they have off and on dysuria or inflammation, which is probably trapping urine under the foreskin, you worry more about those. That's a kid who doesn't have the normal potential for retraction with further growth. They develop scar tissue there it's not going to grow like normal foreskin would. So that's true phimosis that we worry about a little bit and think about earlier therapy rather than later, because if you watch those kids, they won't respond to topical steroids, which we may talk about here in a second, when they have thickened scar. More normal skin responds and scar does not. And you just won't see them get better at puberty either.
So say you've come to the point where it makes sense to intervene. Where would you start with an intervention?
So if the patient is having symptoms, pain or irritation or something, starting with good hygiene, like we talked about, pulling it back when they void, cleaning in the shower, dabbing after they pee. Next step would be if they don't have thick scarred foreskin, like we talked about. If it's sort of normal appearing but non-retracting foreskin, course of topical steroids, triamcinolone and betamethasone. The ointments are probably better. It's 0.5% betamethasone and 0.1% triamcinolone. BID for 4 weeks or TID for 3 weeks seem to be equal in a couple trials that have been done. And I think probably the most accurate data would say 50%. There's data out there that says 80%, but I think the real well-controlled trials are more like 50% will respond to the point that they're dramatically better in terms of their ability to retract. So it increases elasticity in skin. So the preputial aperture gets bigger. It may also release interpreputial adhesions to some degree. That's kind of debated. And then they retract better with that. So that would be the first thing to do. If they respond and get better, they will retain less urine after they void. If they can pull it all the way back, then they can start a whole hygiene routine of cleaning the entire glands.
Is there a recurrence risk after a course of topical steroids?
There is. It's probably 25% at least will re-narrow to the point that they've lost 50% of what they gained.
Okay.
So it's always important for them to know that up front, because they'll be kind of disappointed if not. But I think a lot of folks who prefer the non-circumcised route are very happy to give topical steroids a try. We do a ton of it. Not much lost in those folks who prefer to remain uncircumcised. And
sure,
I think it's a waste of money and some slight risk from the steroids in the kids who have really thickened, scarred foreskin. You just never see those get better with topical steroids. So truly scarred foreskin, is a relative contraindication.
So what's the next step after steroids?
Yeah. So we're talking now symptomatic patients. If they can't retract and they're 8 and they're not having any problems and it's not scarred, just wait. Still okay to wait. And even with a fairly small foreskin, you'll see a number of them get better when puberty hits and testosterone kicks in. For the symptomatic ones, then, the option is full circumcision or something along the lines of a dorsal slit or a modified dorsal slit. And I try to talk to everybody about whether they want to retain the appearance of being uncircumcised. And you can kind of do a distal 50% circumcision and release the narrowed preputial aperture, but leave enough foreskin to at least partially cover the glands.
Mm-hmm.
But you're talking about an older kid's obviously an outpatient surgical procedure at that point. So a little bit of an undertaking.
What's balanoposthitis?
Infection, balano foreskin, balano glands, opisthitis foreskin. So they're almost always together. It's almost everybody just says balanitis because the other's a mouthful and it involves sort of both things.
Right. What causes it? How should I treat it?
Yeah. So can be bacterial, viral, or fungal. And it's basically bugs trapped under the foreskin from poor hygiene. So improving hygiene, potentially using a steroid course to allow for better cleansing. Mild, usually if you think it's bacterial, which is redder, more swollen skin, purulent discharge, topical antibiotic for the milder, oral antibiotic for the more severe, cephalexin, or maybe even Augmentin's a better choice for that, since gram negatives can be there too. Can be fungal. That's a little less red and it's surface red without a lot of edema and sometimes whitish discharge associated. And that's just a topical antifungal.
This is sort of bridging topics, but circumcised boys can sometimes have balanitis as well, right? Would your approach be any different if someone has a foreskin?
No, it would be the same. And for circumcised boys to get it, usually they'll have a little bit of redundancy and a little groove or sulcus at the base of the glands where foreskin rolls up over and keeps things a little bit moist and accumulated there, similar to what an uncircumcised kid would. So real similar approach.
You've alluded to paraphimosis, but it probably deserves a little expansion because it's a bad thing.
Yeah, that's an important one, right? When you're teaching your kid, when they become educatable now and you're teaching them to pull back a little bit and then clean underneath, you got to make sure that if the foreskin comes all the way back beneath glands, sometimes the problem is the preputial aperture is just big enough to stretch and pop over the coronal margin. And then it's like slightly narrowed behind the coronal margin and you have to physically push it distally again. And if you leave it, the glands will get swollen, the skin will get swollen. That's paraphimosis. It basically entrapped. And you can, if it gets swollen enough, like vascular impairment, usually venous impairment and venous engorgement. So teaching them to push the foreskin back into normal position at the same time you start to tell them to retract and clean underneath is pretty important. And the other thing is if they ever can't push it back, to come to you immediately, because before it gets swollen, it's pretty easy to push back. Once it gets swollen, it's pretty tough and occasionally takes an OR trip, sometimes wrapping to reduce edema and things before you can pull the foreskin back to a normal position with or without sedation.
First aid, if someone shows up in my office, what should I try first?
For paraphimosis?
Yeah.
Got it. Probably the first thing is, this is a good little skill because you'll probably run into it. The first thing is to wrap it to reduce edema. You can do it just with physical compression, but if you have something like a little Coban and wrap under tension and then compress for 3 to 5 minutes, you can actually get a good bit of edema out of the penis and make the skin less edematous and have the potential to come back to the right position. When it's really swollen, you won't be able to do that. Then the way to basically pop things back to a normal position is you put both of your thumbs on the glands, like from the top, and then index and middle finger of both hands down towards the base of penis. And then you draw your fingers up towards your thumbs, basically pulling the foreskin up while you push the glands inward. And it's a crux move. It won't go at all. You're pushing the glands, trying to pop it back in while you pull with your fingers, then pop. The glands is back in and you're done. The problem is it's like a blood curdling scream sometimes. because it's pretty tender at that point. So if it's really swollen and we're in the ED, we'll do a little propofol or something like that. But you can do it in the office with modestly swollen kids. Reduce the edema, then thumbs on glands, fingers pulling up the foreskin below. It takes like a 30 or 60 seconds of kind of persistent, gentle pushing, and then eventually the gland just pops in and you'll know it, like, oh, done.
It sounds a little bit like treating an inguinal hernia.
It's kind of right, where you push and all of a sudden things reduce for you. A very similar kind of approach. A little persistence, a minute or two sometimes it takes to make it happen.
And then it floops in. That's a technical term.
That's it. But we know it when we see it or feel it.
Yeah. Going back to balinoposthitis, do you want to mention balinoposthitis erotica obliterans? Not really.
Yep. So BXO, as usually called, is basically lichen sclerosis, which is like a chronic etiology uncertain, more pronounced thickening and whitish discoloration of the preputial aperture, or even more of the foreskin. It can even involve the glands or the meatus sometimes, but it's essentially thickened foreskin to an amplified degree and a real whitish nature to it. That tends to be progressive over time, doesn't really respond to steroids well at all, pretty much requires circumcision to get rid of the narrowed problematic tissue.
Okay. Anything you want to mention about frenulum brev?
So short penile frenulum, probably with uncircumcised penis, the hard thing is when you retract the foreskin and you have a short frenulum, it often pulls the glands downward, almost makes it look abnormal or like they have a mild hypospadias. A lot of those will improve with growth, so we try to leave them alone. If at puberty with erection, they're noticing pain or a lot of downward bending of the glands, at that point, sometimes we'll release that and repair it if it turns out to be problematic, but usually just wait on it until then. Even if it looks a little tight or problematic, many will improve spontaneously.
It also sounds familiar. It sounds like the conversation we have about tongue tie and lip tie. What to do with a frenulum?
Similar issue, different location.
Yep. Anything else we ought to be thinking about?
I think we got it. I think you hit on it at the beginning, Paul. I think part of it is in our culture, a lot of families and us as docs haven't cared for a lot of uncircumcised guys. So you're a little wary of, am I giving them the right advice or not? And I think hands off till they get to that, 5 or 6 years old, usually, then teach them to pull back and dab dry and don't do anything unless it causes problems. And then could be one of those problems we talked about, and solutions are pretty straightforward, but leaving it alone is the way to go.
One of the persuasive statistics for me was, looking at this statistics, was that if 2/3 of males in the world are not circumcised, I think it can be done.
There's no doubt it can be done. If you look at it, it depends on the data. There's probably something like, of uncircumcised boys, something like 2% will eventually come into consideration or get a circumcision for some related issue, right? Whether it's recurrent balanitis or pain or hygiene or something. So a few of them will need it, but the vast majority of the world does pretty well uncircumcised.
Well, thank you very much. And I really appreciate your coming back on the podcast. I should point out peripherally that this episode will be airing in July. And, in Utah, July is when we celebrate pioneers. And I just want to thank you for what you've done for pediatric urology in this region. I mean, you and Brent Snow really pediatric urology is a whole different specialty than adult urology, isn't it? I mean, I don't recall us talking about pediatric prostates yet. And I just really appreciate, you have been an actual pioneer in this region, and I really appreciate it. I think we ought to get you maybe on a urology float in the Pioneer Day Parade.
I don't know what we would put on the urology float, Paul.
I'm pretty sure they would ban it, but
that's a problematic issue there. But I appreciate you saying that. Brent was the first peds urologist in the whole Intermountain area, so I helped him later on as the second guy. But a lot of the real pioneering stuff and advocating for kids in peds urology, give Brent credit for. So thank you for pointing it out.
Well, really, truly appreciate it. For those of you who have questions, please send your questions to questions@bcurb.com, and we'll talk about them next week. Thanks again, Pat, for your time and for your expertise. Thanks to Elisa Stoddard for making this sound like a podcast. Thanks, Janice, for listening, and we'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Paul Wirkus, who also composed the theme music. See you next time.